Thank you very much. I very much appreciate being here in Lund, in this beautiful building, and in this symposium surrounded by this powerhouse of nursing research and interdisciplinary research. It is truly delightful to be here, and I particularly thank Inga, who has been so gracious in her hospitality and also in just making everyone feel so welcome and presenting such a high-quality program. So I'm a professor at Dalhousie, and my research group is at the IWK Children's Hospital, Children's and Women's Hospital, and that is where I hang out for my research. But I live in Ottawa, which is the capital of Canada, and I electronically commute and then physically commute back and forth. I am a volunteer chair of the board of Strongest Families, which I will talk about, and I'm also a private company. I have one that I just started a few months ago for health information. I won't present any data on that, but I wanted to let you know that there are conflicts of interest. Of course, we all have conflicts of interest, and it's important to let them be transparent. So the objectives are to understand the breadth of e-health and its potential to transform health, because I think I've devoted the last 10, 15 years to e-health, and it does have a great potential. But there are a lot of promises that have been made and they have not yet been met. And I want to help you understand the differences between e-health research and e-health in the environment, in the clinical environment, which is quite different. And to be aware of one example, our own example of implementation. So what is e-health? Who knows? It's everything. And it's any use of information or communication technology in the health area. Electronic medical records, of course, are a form of e-health, but ordering systems for drugs could also be a form. The way a radiologist read X-rays and CAT scans and such from their home, that's an e-health. But more narrowly, and much of the stuff that we will be talking about is the interventions delivered to patients or the public by the internet. So there is a difference between e-health and traditional health, and I think we have to understand that difference. One difference is that, of course, it's delivered electronically, but traditional health has been delivered face-to-face, in the presence of a patient and the presence of a healthcare provider. They can be, with e-health, one of the huge advantages that you can be from any location. So you can have, moving from, this morning I emailed a patient of mine who lives in Ottawa about an issue that came up. I do see patients 3 days a week, and an issue came up, and she wrote me, and I wrote her back, and in spite of the time zone differences, it seems that I have provided a little bit of assistance to her. She at least knows that we are there, we are ready to help her, trying to move things forward. There are jurisdictional issues, though. When you cross international or national, even in Canada, healthcare is ruled by the provinces. And if you have one of the people, the provider in one province and the patient or client in another province, there are challenges with that from a jurisdictional point of view. And the different disciplines want to control everything that you do, and if you follow everything that they do all of the time and you don't try and push the edges, you will never do anything that's really that interesting. So I am a bit of a rebel. I hope you will not report me to my college because I could get into trouble. But you have to be willing to challenge all of the rules, because if you simply follow rules, you will simply follow rules and not do much innovation. You can have synchronous e-health or asynchronous, but of course with traditional health, it's always synchronous. The asynchronous use of bulletin boards, for example, hundreds of thousands of patients talk to each other on asynchronous bulletin boards. Asynchronous simply means that one doesn't happen exactly the same time as another. Some of the e-health can be delivered by a computer, not by a person. And this is an area that has a lot of promise with the influx of artificial intelligence, but it also has some very real limitations, and those that we must be aware of, because people, not surprisingly, most of the time we like to interact with other people, although sometimes it's easier to interact with a machine. The other issue where e-health, I think, has most promise is it can collect data automatically. And it can be in the background collecting data that will help us improve e-health, improve the healthcare. But of course, that means that there is a potential threat to privacy. You all have credit cards, and the credit card companies know more about you than your spouse does, than your partner does. They know where you spend all your money, and hopefully your partner doesn't know all of that. So development and evaluation, again, is very different from implementation. Most of the literature that we read is on descriptions or evaluation of programs. These are usually funded by grants. They're pilot projects, or they may be student projects. They have small numbers. So 100 or 200 people in a study is a large study. But much less do we understand when we actually implement something in the real world with not students whose degrees depend on the success of their program, but with ordinary healthcare workers who are dedicated, but they may not be your healthcare workers. They may not be under your control, and they are implementing a program that was developed in the university, and they are in the hospital or in the clinic, and they have no particular love of this program. And there's the real world might be seen as a difference between that and the hothouse of the studies of the university, where everything is protected and everything is monitored, and it's much easier to do things. So the difference is that, for example, in the research hothouse, you handpick your staff. You don't do that when it's actually implemented. Some staff will be highly motivated, some staff will not be. There's a limited number of patients in the original development of something. 200 is a big sample, as I mentioned. But all patients may be subjected to an implementation program. This may be thousands of patients. And what can go wrong with thousands of patients is a great deal more important to understand. There are more resources sometimes with e-health in a research setting. You have your research assistants, you have your research coordinators, you have your investigators, all focused on this program. When it goes into implementation, it's just part of the fabric of the program, and it is implemented, and there's no extra staff to do it usually. Sometimes, in fact, there is a reduction of staff because the e-health is supposed to be doing it. You may not have to conform to all of the rules when you are in doing research, all of the rules in the environment. For example, in my own setting, my research staff are not unionized. The clinical staff are mostly unionized. All the nurses are unionized, psychologists are unionized. So if you are working in a union environment versus in a research environment, my research staff are extraordinarily dedicated. The regular environment are extraordinarily dedicated in the clinical environment, but they run by different rules. And you may have special endorsements when you're doing research. the vice president of research, and somebody else, the professor is right there behind it. But once you go into implementation, it's the same as everything else. Everything is important, and of course, when everything is important, your project is not the most important. So I wanted to tell you about something about the world situation, and I don't pretend to be an expert on global health, but the World Health Organization has been developing and tracking e-health. This is their latest report in global diffusion of e-health, and the issue, they mostly work on a policy level, and their documentation is really quite helpful and quite good, and I would encourage you to look at it. It is done from a very high level rather than from a technical level or a clinical level, although they do have lots of clinical examples. So one of the things in one of their toolkits is this outline of how you're supposed to go about it. And the first thing, of course, is you have to manage the process, and that you have to engage with stakeholders. And the third thing is you must engage with stakeholders. And the fourth thing is you must engage with stakeholders. And the fifth thing is you must engage with stakeholders. Engaging with stakeholders is something that university professors are not used to. We have our ideas, and we know best, and we, along with our small group of students, do what we think is best, and then we publish our papers, and other university professors read those papers, and they say, what a wonderful job you have done. But nobody has to talk, nobody has to interact with the stakeholders, with the nurse on the floor, with the patients, with the managers. You cannot forget that those are the stakeholders, the parents, the grandparents. Those are all stakeholders. And if you want to be successful, you must engage with the stakeholders. And even if you do engage with the stakeholders, that's no guarantee that you will be successful. Most of the time, if you're doing something that is novel, that is innovative, you will fail. That's a good thing, because failure teaches us more than success. Success teaches that that one thing we did was right. Failure teaches us that we have to step back and think about it and make something better. So failure is where we generate new ideas. And I have been a massive failure in my life. And that is why I can come up with a few new ideas. You have to establish the context. You have to learn from trends and experience, and you have to move forward in that way. So I would encourage you to look at the World Health Organization documents for a very good overview of where things are. This is a scale of the global diffusion of e-health, and you can see that it's just going up very, very quickly. It's exploding. And when you have an explosion, you often have some chaos involved. And indeed, at this point in time, there is chaos. And I'll tell you a little bit about what the effect of some of that chaos is. So this is when these are national e-health policies or strategies. And one may say that they're not very important, and I must admit, sometimes I say that. But it is important that you establish a context. This is the country level context. And as you can see, some countries have adopted these and some countries haven't adopted national strategies. A national strategy is an advantage because you can slip into that national strategy and justify what you're doing in terms of a national strategy. A national strategy can be a disadvantage because it may solidify things, may codify things too soon before really innovation can really take ground. The uptake of policies and programs is high, but evaluation is lacking. So what we see is in the university, you have a lot of evaluation. In the general world outside, in the hospitals, you have uptake but no evaluation. And so this contrast, I think, is important to understand. Many programs are instituted in hospitals and in community clinics without any evaluation. And they just keep going. And they either succeed or fail, but they just keep going but nobody checks to see whether they're working or not. And so that's a real contrast. We are consumed with evaluation in the university, but we don't work in the real world oftentimes. Not always. There are some, as we've heard yesterday and today, we'll hear today, that there are many people that are working in the real world of perhaps the tertiary care academic health science center. But that, at least in my country, is very different than the regional hospital, where things are just very, very different. The use of social media is something that we've done a lot, especially in recruiting for our studies. We've also done a lot and are doing more and more within that. And you can see that social media is exploding. I understand that one of the most powerful governments in the world is run by Twitter. And he's also the one that said, who would have thought healthcare was so complex? So I dare not say his name because I want you all to stay there and not throw tomatoes at me. But you know, social media is something that we have to pay attention to. We do have to see how it's expanding so rapidly, both in the developed countries and in the lower income countries. Big data is also coming very fast. Big data, artificial intelligence, machine learning, all of these are moving very, very fast. There's huge developments. They do have a great deal of promise because in the human mind, we can only keep maybe 4 or 5 factors in mind at any one time. And back 50 years ago, there were studies showing the difference between clinical judgment and actuarial judgment, judgment based on data. And judgment based on data in most studies, almost all studies, wins out. Because if I'm using my clinical judgment, I can only keep 4 or 5 things in mind. Whereas a machine can keep 200 things in mind. Or not in mind, but in you know. I even talk as if they're real. But so the problem is that of those 4 or 5 things I'm keeping in mind, some of them will be my own needs, not the needs of the client or patient. And so it's very easy for you to see, and I'm sure you've heard of it, that people say, well, that's the way we do it here. And you say, well, why? I said, because that's the way we do it. Because it's easier to always do the same things because somebody once thought of it that way and maybe did a very good job of thinking it, but we just continue to do it the same way. And certainly in my career, that's been the most frustrating thing to be faced with. People will say, oh, no, Pat, that's not the way we do it here. And we will do it this way. And I said, well, why? He said, because that's the way we do it here. And I say, why? And they say, that's the way we do it here. And so, because it's only based on very little evidence, very few factors involved. But our patients are complex. There are many different factors. And perhaps we should be taking all of those factors into account. But that must be determined by evaluation, by research. Because maybe the same treatment works with everybody. And why should we tailor the treatments if they work the same with everybody? So we have to find that out, and how much tailoring, how much individualization is necessary is helpful, or when does it just become confusing? But big data is going to help us understand that if we can really harness it. I mean, your credit cards and your Google account have used big data so that when you go on, well, today you'll get everything about Black Friday, but when you go on, you looked up something 2 months ago, and your ads will be all about that. And, you know, so you will more likely go back. And there's one thing about commercialization and monetization. It drives it drives things hard because the dollar or the kroner or the pound or whatever, it does rule. Monetization is important. And I always say that when I'm trying to figure something out, I should follow the money, because that tells you an awful lot about what's going on. Because like it or not, our world is based on that. And if you ignore it, you cannot really do the best for your patients. So the stages of development of e-health have been outlined by the World Health Organization. In the beginning, you have experimentation and early adoption. Okay, you have it's all project-based, there's small initiatives, it's disconnected. And in many areas of e-health, that's where it is now. It's still early stages. There's funding by donors and maybe by external granting agencies. Then you get into the middle stage and you're developing and building up project-based larger systems, and there's private sector moves in. And then in scale up and mainstreaming, if we're going to make a difference with e-health, is where we have to go. You have much more comprehensive policy support. You have health sector takes a leading role. There's health information systems are linked at least somewhat, and the industry is active. There may be local businesses emerging. Things are beginning to happen in an organized way. About 20 years ago, this was the promise of e-health that was articulated by Eisenbach. Efficiency, enhancing the quality of care, evidence-based, empowerment of consumers and patients, encouragement of new relationships between patients and health professionals, education of physicians and patients through online sources, enabling information exchange and communication, extending the scope of healthcare. It doesn't have to be in hospitals, it can be anywhere. Ethics, there'll be new challenges, he anticipated 20 years ago, and that there should be equity. That means that the rich and the poor should all receive the same healthcare. In addition, it should be easy to use, entertaining, and exciting. E-health is not there yet. 20 years ago, that was the promise. We have not fulfilled that promise yet. It's still often clunky, it's still isolated, it's still often not linked together, it's still part of a special project. We have a lot of work to do, but it's moving, and it will move either with us from the university, or it will move with the Googles and the Apples. They will run the whole show. I hope not, but I think that is the risk that we face if we don't really move into this area. So what are your guiding principles? As Yogi Berra, who was a catcher in baseball, he said, you've got to be very careful if you don't know where you're going, because you might not get there. And so I have 4 guiding principles that I have about e-health. It should be effective. So I have to do trials to see if something is effective. It has to be efficient. And that's something I never heard about when I was in graduate school, that efficiency was a good thing. It was only when I became a bureaucrat, and I was a bureaucrat, a senior bureaucrat in a vice president's role in hospitals in Nova Scotia for 10 years. That was long enough. It's a very demanding and difficult job to be a bureaucrat. But efficiency is important because we only have a limited amount of money, and if we're not efficient, we will not be able to help more people. Patient, family-centered, including safe. We have to be worried about safety and privacy. We have to be worried about those things. Privacy is actually easier to take care of than safety. We want to make sure that our patients are safe and that it's oriented towards them and their families. Most families can bank any time of day or night. They can go to the stores any time or day or night. But unless it's an emergency, healthcare is only available in very limited windows of time. And it has to be accessible. not just for the middle class, not just for the sophisticated, not just for those who know how to use fancy smartphones. Everybody should have equal access to health. It's a human right, in my view. So I won't go through that, but it can benefit individuals. E-health can benefit individuals, health professionals. It can benefit hospitals and academia. It can benefit businesses, and it can benefit the government. We can do that, but we're not there yet. We've developed a number of tools. This is an e-health mental health toolkit that my group developed for the Mental Health Commission of Canada. There's lots of material like this. Now, I want to mention that I'm going to talk now about some electronic health records and some of the data on them, because I think it's important. This is where most money has been invested in e-health, and yet the promise has not been fulfilled. There's a real challenge with usability in these large systems. How many here use e-health in electronic health records? Could you raise your hands? How many of you love the e-health system? The electronic medical record system? One or two? Not many people love them. And why is that? Because they're not easily understood. It takes a huge amount of time to become familiar with them, and there's real problems with them. So there's many disasters around the world. If you Google e-health disaster or electronic health record disaster, you'll see lots of them. From every company, from every country in the world, you can see disasters. And the challenge is usability. Most of the time, these systems are not user-friendly. They're user-friendly once you know how to do them, but then everything is user-friendly once you know how to do it. But most people, the ordinary doctors or the ordinary nurses, find them clunky and difficult. So there's been some couple of studies from Finland, and I chose Scandinavian studies, but these two studies done by the same group looked at usability studies. The first one was Cerner versus Epic, and two of the major electronic health record systems in Finland. And they did a survey of usability problems. They found that what happened was that there's a lot of usability problems. I won't go into the details. You can get these slides and look up the studies. But the usability seems to be the biggest problem. And these don't get better over time. So they followed up with a later survey. Part of that may be that there's different people coming in, but part of it is that the problems don't get solved. Once the companies sell you the system, they're happy. Their shareholders are happy. That's good. Buy stock in those companies. But they're not necessarily focused on your system and the way you do it. One of the challenges we find in trying to design these things, and I've only been at the periphery of this, is that everybody wants a custom system. The problem with a custom system is that it's customized, so it hasn't gone through any, you don't know if it's going to work. And it's customized to what you want, but then it doesn't work to do what you want, so you become frustrated with it. A recent article looked at 30,000 American Medical Association, the sample was drawn from that. They looked at 5,000 completed surveys, and then they looked at about 1,000 ones in detailed description of burnout and usability. And what they looked at was a burnout inventory and a system usability scale. They found an unacceptable usability and this was all types of different electronic health records. The burnout, especially the depersonalization and emotional exhaustion, was highly related to their rating of the usability of electronic health records. Now, of course, people who are burned out for other reasons may complain more about electronic health records. So this was a correlational study, you can't be certain of causation. But when you reduced the usability, you increased the burnout. a 1 point on this 10-point scale of reduction of usability caused a 3% increase in burnout. And there were large differences between specialties. Some specialties did very well, some specialties did very poorly. So this is a comparison from that article by Melnick and group on the EHR electronic health record scores. They scored on this scale, standardized scale, 45. A Google search scored way up in the 90th percentile, in the 9, so that you have even a microwave is easy to use. Amazon is easy to use. Word is a little bit more difficult, but people can still use it. Global positioning, Excel spreadsheets, which I can't use, were, you know, in the middle there, but way down at the bottom is the electronic health record. Large sample, varied electronic health records. The most common, where we have put more money than anything else in terms of e-health, and it's not usable. Usability, usability, usability. The take-home message is e-health implementation is different from e-health research. There has to be an understanding of usability studies with patients, with families, again and again and again and again. Ongoing usability, because when you change things, you have to check things, and you should be changing things. Outcomes as well, of course, are critical. Implementation has to be planned from the beginning, not as an afterthought. I'm going to tell you a little bit about our own institute, which is a not-for-profit company, and I hope I have a minute or two left. That we're looking, we had a shaky beginning. We started within my research group in the hospital, and then we gradually expanded. This is a federally incorporated not-for-profit company. It's run like a company. We can't make profit because we're a not-for-profit, but we have all of the business systems in place to track all expenses, to track what we do. We deliver care in that institute, and we participate in research. I'm chairman of the board. I don't do any work in it, but a nurse who is my former PhD student is the president and CEO. There she is, much better looking than I am, much more intelligent, much better at business. She is usually selling and making things happen. So we look at education rather than therapy. Because if I call it therapy, then a psychologist has to be involved, and a psychologist in Nova Scotia is not registered in Ontario or Quebec or Manitoba, and so we have lots of problems skirting the rules. We do have very good effect sizes on our outcomes, and these are some of these. You have to be cautious because these are outcomes of a sample of 4,189, and this is a sample. Of course, we don't have a control group for this, so the outcomes, the effect sizes are very large, and it's because there's no control group. But we do have an effect in routine care. The satisfaction rates we get on every patient, every time, and we have very, very high satisfaction rates. We run like a business. We want to make sure that our customers are satisfied. These are the financials, and you can see again that the financials are increasing over time. Our income and our expenditures and our budgets are increasing all the time. We work mostly, as you can see in this one, from the revenue is mostly from service revenue. These are contracts with government-like agencies. We have a small percentage of donations, and grants and research, again, bring in some money, and other donations of equipment and so on bring in some money. We have a multifaceted way of doing it. We're across Canada, and we also have some with the military. We have some arrangements, and we are international, seeing clients all over the world of Canadians who are posted at different places. And again, this is how our staff has grown, so that we're started in the IWK. We started, and then we moved into our Strongest Families Institute, and we've had steady growth. We have to look at those things. I never thought I'd be a businessman, but if you don't do business, then you don't do implementation. And now we're we're reaching about 95 staff, and we should have a budget of over $4 million. This is the software that we use. We developed it ourselves, and this controls much of what we do with our coaches. Our coaches are online with families, and the coaches are not psychologists. They're not social workers or nurses. They're just ordinary people that we hire, and we train them. We're more interested in competence than in credentials. And I'm going to stop there and thank some of my funders and appreciate your time. And I appreciate you listening to me so well. Thank you.